Welcome back to part 14 of our 20-part Dental Coding Masterclass Explainer. So, in part 13, we really got into the weeds with fractures and cracked tooth ICD-10 coding. But today, we are shifting gears completely to unpack the billing guidelines of CDT Category I diagnostic services, specifically codes D0100 to D0999. If you are navigating the revenue cycle, mastering these clinical oral evaluations, frequency limits, and bundling rules is absolutely essential. Let's dive right in and demystify this together. Here is a quick look at our agenda for today. We'll start with clinical anatomy context, then tackle the limited oral evaluation, D0140. After that, we'll cover the comprehensive evaluation, D0150, move into pre-diagnostic screenings, and finally, wrap up with counseling and oral hygiene.
All right, Section 1, Clinical Anatomy Context. Before we even think about dropping codes, we've got to ground ourselves in the clinical reality of what these providers are actually assessing. Dentistry evaluates conditions across the entire oral cavity, right? From the visible protective enamel crown all the way down to the super sensitive inner pulp, the roots, and that stabilizing periodontal ligament. When you bill an evaluation, you aren't just billing for a quick glance. You are billing for the assessment of some seriously massive, complex clinical real estate.
Moving right along to Section 2, the Limited Oral Evaluation, code D0140.
Okay, so D0140 is typically your problem-focused exam. This is for when a new or established patient walks in with a specific acute complaint. Think dental trauma, an acute infection, a broken tooth, or just severe localized pain. But here is the catch, and it's a big one. D0140 is strictly an evaluation code. It is not a treatment code. If the provider's doing minor procedures just to alleviate the patient's pain, you really need to be reporting D9110 for palliative care instead. Which brings us to a major bundling trap. Listen, insurance carriers have incredibly strict logic engines built into their systems. They are absolutely going to deny reimbursement if you try to report that D0140 evaluation and the D9110 palliative treatment on the exact same date of service. Plus, if you bill D0140 on the same date as definitive treatment, you can definitely expect a denial there too. Because of these wild frequency limitations and payer rules, a lot of practices make a highly calculated, strategic choice. They actually just withhold reporting D0140 entirely for those minor visits. Why would they do that? Well, to save the patient's evaluation allowance for routine exams like D0120, the periodic oral evaluation. Just as a quick reminder, D0120 is used for your routine recall cleanings, and it includes oral cancer evaluations and periodontal screenings. It's usually capped at once every 6 months to the date, or sometimes twice a calendar year depending on the carrier. So by skipping the D0140, they ensure the D0120 gets covered later, especially since D0120 is so commonly billed alongside codes like D0210, D0330, bite wings like D0272 or D0274, and cleanings like D1110 and D1120.
Okay, Section 3, the Comprehensive Evaluation, D0150.
This operational strategy brings us to the real heavy hitter of diagnostic evaluations, D0150. This is a deep dive used by both general dentists and specialists. It involves a comprehensive recording of extraoral and intraoral tissues, oral cancer evaluations, and a thorough medical history and general health assessment. But who actually gets this? Usually, it's brand new patients, established patients with significant systemic health changes, or established patients who haven't had active treatment for 3 or more years. But beware, the revenue cycle trap here is brutal. Many plans restrict this code to a literal once-per-lifetime limitation per carrier.
So what exactly do you do when you hit that frustrating once-per-lifetime wall? Well, you definitely don't just write off the balance. You need to proactively request the alternate benefit of D0120 to secure that reimbursement. It's essentially a simple downgrade to the periodic oral evaluation, but it captures revenue that would otherwise just disappear into the void of a frequency denial. Next up, Section 4, Pre-Diagnostic Screenings. Now we need to distinguish between two very specific limited visual oral assessments, D0190 and D0191. Putting these side by side makes the nuance crystal clear. D0190 is just a basic preliminary visual screening, mostly just to see if a patient even needs a full dental evaluation. You'll see this a lot with state or federally mandated school screenings. D0191, on the other hand, is a much more detailed clinical inspection by a dentist or auxiliary staff. They're actively looking for signs of oral or systemic disease, malformation, or injury to figure out if a referral is necessary.
But let's be real for a second about the reimbursement reality here. You really need to keep your revenue expectations grounded. Both of these pre-diagnostic codes are rarely, and I mean rarely, reimbursed by your standard commercial carriers. You're typically only going to see these paid out by specific government plans, like Medicaid.
All right, final stretch. Section 5, Counseling and Oral Hygiene.
Let's talk about how to accurately code for specialized counseling under this diagnostic category. First is alcohol and substance misuse counseling. This is officially reported using the SBIRT protocol, which stands for Screening, Brief Interventions, and Referral to Treatment. The absolute key for compliance here? This has to be provided by a certified, licensed professional operating strictly within their scope of practice.
Then we have the absolute bread and butter of patient education, D1330. Whenever a provider sits down for true one-on-one home care education, this is your code. We're talking highly individualized toothbrushing techniques, specific flossing guidance, dietary recommendations, and teaching them how to use adjunctive products like therapeutic mouthwashes or interdental brushes. And just to be completely clear, handing a patient a generic printed pamphlet, yeah, that does not qualify for D1330.
The best part about D1330 is how versatile it is for your billing. You can actually bill it on the very same day alongside cleanings, comprehensive evaluations, and even x-rays. And hey, speaking of x-rays, that tees up part 15 of our masterclass perfectly. In our next explainer, we are diving entirely into CDT Category 1 diagnostic imaging. We're talking bite wings, periopicals, panoramic, and full mouth series. You won't want to miss it.
But as we wrap up today's explainer on these evaluation and screening codes, I really want you to take a hard look at your current processes. How are you going to optimize your coding for D0140 and D0150 to prevent those nasty carrier denials? Are you accidentally burning through your patient's allowances? Are you bundling D0140 with palliative care and getting slapped with denials? It is time to optimize. Keep mastering these CDT codes and protect that hard-earned revenue cycle. If you found this explainer helpful, please hit that like button, subscribe to the channel, and drop any of your coding questions in the comments below. Be sure to check out the full masterclass playlist for the rest of the series. Keep learning, keep optimizing, and remember, decode healthcare with Harshal.